Tachycardia-induced cardiomyopathy, often referred to as arrhythmia-induced cardiomyopathy, is a unique clinical entity where persistent or frequent tachyarrhythmias lead to significant ventricular dysfunction. The hallmark of tachycardia-induced cardiomyopathy is its potential for partial or complete reversibility once the heart rate is controlled or the rhythm is restored. The exact mechanisms are complex, but cellular and structural changes typically include depletion of high-energy phosphates, ATP and phosphocreatinine, and reduced mitochondrial efficiency. Abnormalities in sarcoplasmic reticulum calcium ATPase, that is SERCA2A activity, leading to impaired excitation contraction coupling. Myocyte elongation, loss of myofibrils, and increased extracellular matrix collagen deposition, though notably with less prominent fibrosis than other dilated cardiomyopathies, which explains the potential for recovery. Reduced subendocardial blood flow and coronary flow reserve due to shortened diastole. While any sustained tachycardia can cause tachycardia-induced cardiomyopathy, the most frequent culprits include atrial fibrillation, the most common cause, particularly when the ventricular response is poorly controlled. Atrial flutter, especially 2:1 conduction leading to sustained rates around 150 beats per minute. Frequent premature ventricular contractions typically requires a high burden, often 15 to 20% or more of total beats, though tachycardiomyopathy has been observed with burdens as low as 10%. Supraventricular tachycardia, including permanent junctional reciprocating tachycardia, PJRT, and WPW syndrome. Incessant ventricular tachycardia, often originating from the outflow tracts. Tachycardia-induced cardiomyopathy is often a diagnosis of exclusion or confirmed retrospectively. Key indicators include 1. Reduced left ventricular ejection fraction, dilated or non-dilated LV with reduced ejection fraction. Persistent tachycardia, usually defined as heart rate more than 100 beats per minute for a significant portion of the day. Absence of other causes, no significant coronary artery disease, valvular disease, or primary myopathy that fully explains the degree of dysfunction. Recovery, improvement in left ventricular ejection fraction, usually within 1 to 6 months following effective rate or rhythm control. The primary goal is normalization of the heart rate or restoration of sinus rhythm. Rhythm control by catheter ablation, highly effective for PVCs, AFib, or SVTs. Ablation is often preferred over long-term pharmacotherapy in tachycardiomyopathy due to higher cure rates. Rate control, pharmacotherapy, beta blockers, non-dihydropyridine calcium channel blockers like verapamil or diltiazem, or digoxin. Advanced options, ablate in pace. AV node ablation followed by permanent pacemaker or CRT implantation if pharmacological rate control fails in atrial fibrillation. Heart failure management. Standard guideline directed medical therapy includes ACE inhibitor, ARB, ARNI, MRA, SGLT2 inhibitors should be initiated while waiting for recovery. Here are a few clinical considerations. The double hit. Tachycardia can be the primary cause of cardiomyopathy, or it can exacerbate an underlying substrate. Example, a patient with mild hypertensive heart disease who develops atrial fibrillation. These two varieties have been called as pure and impure tachycardia-induced cardiomyopathy. Recurrence risk. Even after recovery of left ventricular function, These patients remain at high risk for tachycardia-induced failure if arrhythmia recurs. There is often a memory in the myocardium where LVEF drops much more rapidly during a second episode. PVC morphology. PVC originating from RVOT or LVOT are common targets for ablation. Identifying the origin via 12-lead ECG is critical for planning intervention.